So, hello everyone, welcome back to my channel, and I'm here to discuss the part 2 of spinal dysraphism. So, going with the flow, we already have discussed these two varieties, and today we will discuss these two categories. Okay, so let's first start the simple dysraphic states. Okay, this includes three disorders: the intradural lipoma, the lipoma of phylum terminale, and persistence of the terminal ventricle. So the first is intradural lipoma. Okay, intradural lipoma, as the name suggests, there is one lipomatous lesion, and that's contained within the dura. So here fat is contained within the dural sac, and it can be like focal, multifocal, or it can be even diffuse. Okay, and it can grow as the child ages. Okay, it grows with the child age. At MR, what will you see? As it is lipoma, fat means we have to look for T1. So this is the T1 image. Here we can see an oblong shaped T1 hyperintense. It will be hyperintense on T2 also. So there is fatty lesion in intradural space, and in the axial images you can see this fatty lesion in the intradural space, and it is seen displacing and causing mass effect over this spinal cord. Okay, it can displace and cause mass effect over the spinal cord, and in some cases, as the name intradural, but in some cases this lipoma can be even intramedullary. Okay, and this intramedullary lipoma can be focal or can even be multifocal or diffuse disease. So first is intradural lipoma. Next one is lipoma of phylum terminale or the filar lipoma. Okay, again we have to look for the T1 image because we are talking about fat. So small lipomatous lesion is seen in the phylum terminale region. As this is the T1 image, you can see a thin fatty lesion in the region of the phylum terminale. In axial image also you can confirm it, small lipomatous lesion in phylum terminale region with no communication with the medullary cone. Okay, and this can be like associated with the third cord syndrome or caudal regression type 2. These two we'll discuss later in this video. Okay, next one is persistence of terminal ventricle, or also known as the fifth ventricle. Okay, persistence of the terminal ventricle. So what we can see here in the conus medullaris, the terminal part of the spinal cord, there is this cystic cavity. Can you appreciate a cystic cavity in the terminal part of the conus medullaris, which is following the signal of CSF, a cystic cavity in conus medullaris, and it does not show any post-contrast enhancement. This cystic lesion shows continuity with the central canal of the rostral spinal cord. Okay, this continuity is preserved. So we have discussed the three simple dysraphic states: the intradural lipoma, lipomatous lesion in intradural sac, lipoma of the phylum terminale seen on T1 images, and the fifth ventricle or the persistence of terminal ventricle. Next one, let's discuss the complex dysraphic states, and amongst that the first one is dorsal dermal sinus. Okay, so dorsal dermal sinus or tract, actually there is a midline fistula. Okay, see this, there is this overlying skin, there is this opening, and there is an ostia, midline fistula lined by epithelium that is actually connecting the skin surface with the CNS or its meningeal membranes. So what we can see, there is an ostia, there can be associated skin stigmas at that site like hyperpigmentation or trichosis, etc. And then there is a tract which is going through a defect in the posterior element of the vertebra into the dura or the other meningeal covering up to the spinal cord. Okay, it can go from skin to any level of the subpal space, and as because of this opening there is communication with the exterior, so the patient can suffer with recurrent meningitis. This fistulous tract can get infected and form abscess, and there can be CSF leaks also because of this. Okay, and these are very frequently associated with dermoids and epidermoids of the spinal cord. Okay, so dorsal dermal sinus, how to visualize this on sagittal and axial images? Like in this case you can see a T2 hypointense tract from the skin subcutaneous tissue to a defect in the posterior element is it is seen going within the dura, and we have to look where this dorsal dermal sinus tract is terminating at what level. Okay, see the terminating at what level. And we have to also take the diffusion images to rule out any dermoid, epidermoid, and also we should have contrast images to look for any infection associated with the sinus tract like abscess formation. Okay, so this is dorsal dermal sinus. Next one is the diastometamylia. So what it is the longitudinal split of the spinal cord. The spinal cord is split into two halves. Okay, there are two types of this diastometamylia, type 1 and type 2. What happens in type 1 is there are two separate dural sacs, and these are separated by a bony or a cartilaginous septum. Okay, there are two dural sacs. But in type 2, both the spinal cord halves are contained within a single dural sac. Okay, so in type 1, there are duplicated dural sacs, there is a common midline osseous or cartilaginous septum, and they are usually asymptomatic. They are associated with severe vertebral body anomalies and syringohydromyelia. Okay. Type 2, there is single dural sac with both the hemichords. There is no midline spur, or there can be very thin fibrous spur which is not well visualized on MRI. These are less symptomatic. There are less severe degree of vertebral body anomalies, and there is less severe degree of syringohydromyelia. Okay, so let's see these. So here in this MRI images, what we can see, there are two separate dural sacs separated by a midline bony septum, seen in these images also, and there is upstream associated syringohydromyelia. So there are two dural sacs, and both these spinal cord halves have their own meninges and two nerve roots. Okay, ventral and the dorsal ones. This is type 1. Type 2, single dural sac. Okay, there is no septum contained within a single meningeal lining, and both these hemichords have their own roots. And in this case also we can see syringomyelia, and these can be associated with like third cords and any spinal lesions like spinal intradural lipoma, etc. Okay, so but in usually these type 2 diastometamylias are less symptomatic, less associated with vertebral body anomalies, and less associated with syringohydromyelia. But in this case we can see syringohydromyelia, we can see the cord teethering, and we can see a spinal intradural lipoma as well. So in this image, see, this is definitely a osseous spur. So this is type 1. This is type 2, where there is single dural sac, and when you see the spinal cord one section above, the cord is united, then it divides into two halves, and then again just below that level it again reunites to form single spinal cord. Okay, so this is diastometamylia. Next one is caudal regression syndrome. Okay, caudal regression syndrome. What happens there is that there is lumbosacral agenesis, and they are associated with various lower limb genitourinary, gastrointestinal and respiratory organ anomalies. Okay, like bacterial syndrome, Currarino triad, and all these. So the caudal regression syndrome means there is lumbosacral agenesis. Okay, so these are also of two types. Okay, the type 1 is more severe form, just like type 1 diastometamylia, which is more severe. Similarly, caudal regression type 1 is also like more severe. There is major vertebral dysgenesis. Okay, like in type 1, the vertebral bodies from lower thoracic to coccyx level may be absent. Okay, so there is major severe degree of vertebral dysgenesis. So one, we have to look for the vertebral bodies. Then next look for the conus medullaris termination. Usually in type 1 the conus terminates at a higher level, and the termination is also very abrupt. Like in normal cases the conus should end like a cone manner, but in cases of caudal regression type 1 the conus has very blunt ending. Okay, and that too at a high location. And when we see the axial images, then there is this parallelism or double bundle appearance because of this abnormal course of the neural elements. Okay, so see, the cord is terminating at a much higher level, then the cord ending is also blunt, then majority of the sacrum and the coccyx vertebra is not there. Okay, so this is caudal regression syndrome type 1. Next is the type 2, where there is less severe form of vertebral dysgenesis, like there is segmental agenesis of few of the sacrum or like coccyx. Okay, but these type 2 are very much associated with tethered cord syndrome. Okay, tethering of the cord. Why tethering? Because of some mass. What form of mass? Like lipomyelomenincocele, any lipoma, any sacral, anterior sacral meningocele. Okay, and the conus is low lying here. Okay, in type 1 there is major vertebral anomaly, the conus is terminating at a higher level and bluntly, but in type 2 there is less degree of vertebral agenesis and the conus is low lying and tethered. Why tethered? Because of some mass like lipomyelomenincocele, lipoma, anterior sacral meningocele. Okay, this is the caudal regression syndrome. Two disorders are remaining, and they are like limited dorsal myeloschisis. Okay, these are of two types, saccular and non-saccular. What happens, there is one stalk that is connecting the skin with the spinal cord. Okay, so the closed differential is dorsal dermal sinus. Okay, and another is segmental spinal dysgenesis. So what happens there? There is localized agenesis or dysgenesis of the spinal cord and the spine. Okay, and the closed differential is caudal regression syndrome. I want you to study these topics by yourself. Okay, if you have any doubt, let me know. I'll teach them in separate sections. Okay, if you have noticed, I have taken two terms throughout this video that now I want to discuss, but before that, let's know where the spinal cord terminates. Okay, so the spinal cord ends at lower border of L1 vertebra. Okay, the spinal cord, the conus ends at the lower border of L1 vertebra. The dura and the arachnoid matter but continues up to the S2 level, the dura and the arachnoid, and the pia matter below the conus becomes phylum terminale. Okay, and this phylum terminale goes downwards and attaches to the posterior surface of coccyx. Okay, spinal cord at L1 level, dura and arachnoid at S2 level, and pia matter at the posterior surface of coccyx. So spinal cord ending L2, L3 disc level or above at any age is normal. Spinal cord ending at L3, L4 disc or below is abnormal, except few exceptions like premature infants and full-term newborns. Okay, L3 is equivocal. Spinal cord terminating at L3 is equivocal, and you have to decide by other means. So if I take one value, then spinal cord ends at L1 vertebral level. Okay, so there is one term, that's tethered cord syndrome. Okay, tethered cord syndrome means it is actually a neurological disorder because of a tissue attachment. Okay, the spinal cord usually is free, terminating at L1 level, but in tethered cord syndrome, what happens, there is some tissue that is attaching the lower limit of the spinal cord and thus it limits the movement of spinal cord within the spinal canal, and thus as there is no movement as the child grows, there is some stretching and ischemia of the spinal cord because the cord is attached, is tethered, so it causes symptoms like weakness of the lower limbs and so on. So what happens, there is tethering kab hogi, whenever the spinal cord is like low lying, so low lying conus, but tethering is possible at the level of normal conus position also. So low lying conus, and there can be some tethering agent. Okay, like any kind of lipoma, dorsal dermal sinus, dermoid, okay, dastometa tight phylum terminale, all these are causes of tethering. So we have to look where the cord is ending, the level of the conus terminating. We have to look for the phylum terminale. We have to look for any lesion, any tethering agent that is caused tethering, and we have to look for vertebra, is there any spinal dysraphism. And also when you do the prone imaging, then you can see the cord is more towards posterior aspect. Okay, so this is tethered cord syndrome, the level of the conus, the phylum terminale, any tethering lesion, and any bony dysraphism. And the next point is tight phylum terminale. Okay, so the phylum terminale is we are calling it tight. Why? Because it is either thick or short or inelastic. Okay, when phylum terminal would be short, when the conus is low lying, okay, like below L1 L2, okay, the conus is low lying, so the phylum terminal would be shorter. Thick, when the thickness of the phylum terminal is more than 2 mm, and usually they are fatty phylum terminal. Okay, so I think we should know the levels where the spinal cord, dura, arachnoid, phylum terminals are ending, and by this related two terms like the third cord syndrome and the tight phylum terminal we should also know. And by this I think spinal dysraphism is like clear to you. If you have any doubts regarding this topic, you can ask me, and I'll be very happy to post the part 3 of this video also. So thank you so much.